get started with this month's installment of our Resuscitation Academy Heart Rescue webinar. And this forum serves many different, features many different topics and people. We often will focus on a particular intervention or population or program, but today's forum will actually feature a person, which is something that we haven't done too much in previously, but I think it's a great idea, and I don't think we could have picked a better person than Dr. Fionna Moore from England to be our featured guest and presenter. Before we get started and turn it over to Dr. Moore, there are a handful of announcements and comments that I want to provide to the group. The first is just to provide reminders about some of the conferences coming up stateside. So there is the REST conference in Philadelphia that's sponsored by the American Heart Association and really features sort of new science and innovation. And it's going to be, I think, the second week of November. And then in the first week of December is the Citizen CPR Foundation ECCU meeting, which is really a great gathering that features the new science and really puts an implementation angle. They also dedicate quite a bit of effort to highlight survivors and understand some of the unique circumstances that families, survivors, and others have in cardiac arrest resuscitation. So both of those conferences are good investments, and they really do provide a lot of interesting perspective and new information. So that's announcement number one. Announcement number two, I want to turn to Mary Newman, who's joined. And Mary, I know there's a conference coming up, a webinar right after this that your group is hosting. So Mary, you want to announce that?
Yes, thank you, Tom. The Cardiac Arrest Survivor Alliance has a webinar right after this webinar, and it will be about reflections of an SCA survivor caring for other survivors. The webinar will be led by Dr. Josh Lupton, who is an assistant professor of emergency medicine at Oregon Health and Science University. And I think he's on the line. Yeah, maybe Josh, you want to say a few words?
Yeah, nothing. Yeah, feel free to join. It'll be 20 minutes or so, and then 10 minutes, a bunch of survivors will be there. It'll be a fun discussion, and but there'll probably be takeaways, even if you're a healthcare provider, for sure.
Well, thanks, Mary, and thanks, Josh. I wonder, Mary, if you want to drop the link to that webinar that will follow in the chat, and so people have access to that. I think that's great. And Josh, welcome. You are doing great work down there in the Portland area, and it's great to see you today. All right. Well, let's turn our attention to Dr. Fionna Moore. Dr. Moore has, I think, a very important career in pre-hospital emergency care. She has led two of the largest ambulance systems in England over extended periods of time, with all kinds of turns and twists in that career. And we asked Dr. Moore if she would reflect on the challenges and the accomplishments and provide insight based on her experiences. So Fionna, would you like to take it away?
Yeah, thanks, Tom. It's a huge honor to be asked to do this webinar, so thank you very much. Thanks to Andol as well. I don't know why I agreed to this, particularly now that I know that Douglas is on the call, but there you go. And thanks very much to Tegan, who's going to run the IT for me. So Tegan, if you could bring up the slides, and we'll do what Professor Chris Whitty did during COVID, which is do the next slide, please. So I'm just going to give some reflections on my career. It's very much a personal reflection. So if we could go on to the next slide, please. There are no conflicts of interest to declare, other than they are very much my own opinions, and inevitably it's very much England's centric, and in particular from London and from the southeast. So next slide, please. So I've just reflected a bit on my journey. I've been in medicine now since I became a medical student over 50 years ago. A bit about the highs and the lows of where I've been and what I've learned. I wanted to reflect on some of the amazing people that I've worked with, as well as the 2 ambulance services that I've had the privilege to serve. I wanted to talk a little bit about the development of pre-hospital emergency medicine as a subspecialty of emergency medicine and anaesthesia. A bit about the future, and just some really nice photographs of the bits that have been a great bit of my career. So next slide, please. So in terms of emergency medicine, I always wanted to be a doctor, apart from when I was about 10 or 11, when I thought flying fast jets would be a great thing to do. But back then, it wasn't really considered to be the right sort of career for a young woman. So it had to be medicine. I qualified in 1970, well, actually late 74, and my career was going to be plastic surgery. But that didn't really go very far, so I went back into general surgery. And then in 1982, emergency medicine was just starting as a career option. And that's when I saw the light and was a senior registrar in a hospital called Ealing in West London, which saw some of the most amazing pathology. I then moved on to be a consultant at both University College and the Middlesex hospitals. In fact, when I took up that post, 3 weeks after I started, they announced they were going to close the emergency department at the Middlesex, which was absolutely nothing to do with me. In fact, my biggest memory of being a consultant at the Middlesex was that my car was stolen from the consultant's car park. And my consultant colleagues didn't show any great sympathy. However, I then worked in Oxford for a couple of years before returning to London, and I've currently got an honorary consultant post at Imperial College Healthcare Trust, although currently I do my clinical shifts in pre-hospital care. Next slide, please. So in terms of my background in EMS, the consultants in London set up a group with the London Ambulance Service to ensure that there was good liaison between the 2 organisations. And I became the chair of that in 1985 when I was a very junior consultant. I think the first meeting was when I first joined. The second meeting was 2 years later. So it wasn't exactly a thriving group. But I became the chair of the Paramedic Steering Committee, which was a committee that every ambulance service in England was required to have, and then became the medical director of the London Ambulance Service in 1997, a post which I held until 2015. And when I first started, the general feeling from my colleagues in the ambulance service was that they thought doctors were absolutely fantastic people in their place, and that place was not in the back of their ambulance. I had a brief period as chief exec of London between 2015 and 2017. And then I had the great privilege, and I make that point particularly for Douglas, of becoming the medical director of South East Coast Ambulance Service, because that is the ambulance service that he has supported for probably 70 years. And it's one of the reasons that it is a particularly great service. I was the interim chief exec for a brief period of time. I just made the comment there that some people never learn. And I've now moved on from the ambulance service, or the statutory ambulance service, and I'm working as a senior medical advisor for the air ambulance charity of Kent, Surrey and Sussex, which is great fun. Next slide, please. So just some of the immense privileges of working in this post. One of the advantages of being in London is that you have you're coterminous with both the London Fire Brigade and the Metropolitan Police. And the photographs in the bottom right of the slide are the commissioners of those 2 services that I had the privilege to work with. And just above that, for a very brief period of time, the commissioners for the 3 emergency services in London were all women. I have to say it didn't go terribly well, I guess, for any of us. So poor Danny was the Commissioner of the London Fire Brigade for the Grenfell fire, and my colleague from the Metropolitan Police had a major fallout with the London Mayor, which is never a good thing to do. However, for me, it was a huge privilege to lead the London Ambulance Service, and I worked for some amazing people. And on the left-hand side there is the memorial for the 2005 bombing which we held in 2015, when I had the privilege to lay a wreath along with the Commissioner of the Fire Brigade at the memorial in Hyde Park. I also show a picture of one of the greatest paramedics in the London Ambulance Service, just shown on the left-hand side there, David Whitmore, who was my friend and colleague throughout my time in the LAS. Next slide, please. Then for me, there were some game changers, and in the middle of the screen at the top, you will see my mentor and colleague, Professor Douglas Chamberlain. And Douglas, I didn't know you were going to be on the call, so this was not a setup. Next to him is Dr. David Zeiderman, who, like Douglas, was a chair of the Resuscitation Council UK, and had an enormous role to play in the London Ambulance Service, particularly when we were instituting the training of paramedics. And any paramedic who had difficulty in managing their airway skills was sent off to work with David at the Hammersmith Hospital. On the left-hand side of the screen is Peter Bradley, who was the Chief Executive of the London Ambulance Service and is now the Chief Executive of St John in New Zealand. Another individual I'd like to highlight is just standing beside me at the bottom there, Mark Whitbread, who is a consultant paramedic, who is a phenomenal teacher and dedicated to teaching paramedics in recognizing ECG patterns, and set up the cardiac setup within London. So, and top right, sadly died earlier this year, Dr. Howard Baderman, who was one of the earliest consultants in emergency medicine in the UK and an advisor to the Department of Health. So all people who had an amazing impact on my career. Next slide, please. Some special moments. Sadly, some of the special moments that you have as a chief executive are around saying goodbye to people. And on the right-hand side of the screen, one of my colleagues who set up the booze bus, which was a vehicle that used to go out to people who were inebriated and take them to centres where they could be looked after. I think you call them inebriation centres in the States. He died, sadly, of a major brain hemorrhage, but we held a fantastic funeral for him, and you can see just below him the cycle response unit, which is something we set up in London, all lined up to say goodbye to him because he had been a member of that unit. We had a paramedic who had served for 50 years. He is shown in the top centre of the screen. He was still working as a paramedic, having been there for 50 years. And then photographs from the Pride celebrations, both from the London Ambulance Service and from South East Coast. Both ambulance services have a really liberal view around LGBTQ plus people. Perhaps we're not so good with other forms of diversity, but that is an area that we excel in. Next slide, please. And for me, some amazing moments were cycling to Paris with the LAS cycle team and taking a vehicle around the Arc de Triomphe, and having my kids cycling with me. So that was, it was actually an extremely wet trip, but great fun even so. Next slide, please. And then some of the successes that we had. We introduced critical care paramedics in London, and you can see one of them standing with a large red bag in the middle of the slide. We had a number of really successful campaigns. The Eat, Drink and Be Safe was around ensuring that you got yourself home safely after being out drinking and celebrating Christmas parties. We set up the defibrillator scheme in London. You can see that on the top left. We managed to persuade the Masons to donate 4 fast response cars to us. And we employed the first consultant midwife to support an ambulance service. And that is now something that a number of ambulance services do. and it is something that I think has been phenomenally successful in training our staff and supporting our staff. And then bottom right, there are the photographs of the cardiac arrest on the football field at White Hart Lane when Fabrice Mwanda had his cardiac arrest, from which he was successfully resuscitated, and now is a great campaigner for screening for footballers and for a bystander life support. And that incident have been important in the Resuscitation Council UK taking forward the resuscitation on the field of play protocols. Next slide, please. Then, of course, there was the 6th of July 2005. Next slide, please. When London learnt that we were going to host the London Olympics in 2012, which was a fantastic day. However, next slide, please. The next day wasn't so great. That was the 7th of July 2005, when the bombs exploded on the undergrounds and subsequently on a London bus. And initially, the London Ambulance Service and indeed the emergency services were hailed as having done a phenomenal job. But as time went by, it became increasingly obvious that there were a number of patients who had probably waited too long for us to get to them, particularly in the train that was bombed in the tunnel going between King's Cross and Holborn. Next slide, please. And it took a long time for the inquest to be heard, and if that wasn't until 2011, and you can imagine the difficulty for all the families of the 52 victims that you can see in the slide there, with the memorial to them in Hyde Park below. And the inquest was held by a High Court judge, Dame Heather Hallett, who is now undertaking the inquiry into the COVID into the COVID pandemic. And that inquiry found that there were a significant number of lessons that we in the LAS could learn, particularly around triage and treatment. So rather than just triaging patients and moving on, there was triage and immediate treatment. So that was a difficult time for the staff who'd been involved in the London bombings, who only were asked to go to the inquest and relive all that, along with the relatives and family of the victims some 6 years after the incident. Next slide, please. And then I thought it was worth reflecting on the issues we had when we replaced our computer-aided dispatch system. So we moved to a system called Command Point, and that was intended to come in by 2010. In fact, we didn't get it in until 2011, and it failed within 10 hours. And it took us another year and a half to get it back in, and in fact was only functioning fully 6 weeks before the Olympics. So that was a pretty closely run thing. And the lesson there is that if you are going to buy an off-the-shelf system, then don't tinker with it like we did, because we put in a significant number of response profiles, which made it a very much more complicated system than it was ever intended to be, which is why it fell over. So next slide, please. And then we had the Olympics, which was fantastic. And it was one of the happiest times in London. People were smiling, even on the tubes, even on busy tubes. It was fantastic. And for me, I guess, typified by the opening and closing ceremonies, by that fantastic video of late Majesty the Queen jumping out of a helicopter and being shown with James Bond and the corgis. Next slide, please. Of course, we had not just to keep the rest of London safe, but to put in a significant response to the Olympics. And what you see in this slide is a warehouse in East London, which was converted into the Olympic Deployment Centre, and 60 ambulances all lined up, ready to go. A fantastic site. It has to be said that although those were 60 fully kitted ambulances, within about 6 weeks, we had great difficulty in finding all the kit, but that's an ambulance service for you. Next slide, please. We had a huge amount of help from colleagues across the United Kingdom, And we got them all down before the Olympics. We talked to them about how things were going to run. They told us how they did things. We negotiated how we were going to do things. And it was all an extremely successful Olympics, both for them because they loved being in London, and for us because it was great to be able to share the city with people from across the country. Next slide, please. Surprisingly, you would have thought that during the Olympics, people would be keen on attending the Olympics and watching their TVs. But as you can see from this slide, the red line, which showed the activity during the summer of 2012, was even greater than it had been over the previous 2 years. So even if you've got the Olympics running, you're still going to be pretty busy, and people still rang 999 during the Olympics. Perhaps that was because we had so many visitors who came to London. Next slide, please. And then we had the opportunity to realise the legacy from the Olympics. And some of that was around utilising the facilities that we developed over the Olympics, such as the Olympic Park, which is still up and running to this day, such as encouraging young people to participate in sport. And that certainly worked for the first couple of years, but I don't think that it's been realised to the same extent since then. And then, of course, we got the then Mayor of London and subsequently our Prime Minister, Boris Johnson, to learn how to resuscitate. He had to be restrained a little bit. I haven't ever seen chest compressions done quite so quickly. And getting him to reduce his rate from 210 to a more reasonable rate needed the impact of those individuals who were the Olympic ambassadors. Next slide, please. I also had the privilege of introducing the London trauma system between 2009 and 2012. And that was as a result of a document called Trauma Who Cares, which is the last of a series of documents demonstrating that trauma was badly managed in the UK by seriously injured patients going to the nearest hospital. And finally, in 2012, we were able to establish 4 major trauma centres in London, along with 4 networks reaching out across London and into the counties around it. And the evidence from that has demonstrated significant improvement in survival from major trauma. That project also allowed us to introduce training courses for trauma team leaders and for trauma teams, as well as protocols to allow our ambulance crews to take patients direct to major trauma centres, bypassing local hospitals. Next slide, please. It wasn't all plain sailing. We have strikes going on at the moment, but we had strikes back in 2014-15. And that faced us with the challenge of how do you run a service when you don't have any staff? And for the strikes at the latter part of 2014, 80% of our frontline staff either didn't attend or worked to rule. Fortunately, virtually all of our control staff attended, because if you can't take incoming calls, you've got no idea what your outstanding demand is. Next slide, please. We were supported by the military, and the slide on the left-hand side shows ambulances lined up outside Wellington Barracks, which is in Horse Guards and very close to Buckingham Palace. And that was an amazing sight. And we had a weekend to prepare approximately 200 members of the military to drive ambulances and to attend. We had healthcare professionals as the attendant on the vehicles, but military staff, both from the Navy, the Army and the RAF, drove the ambulances. They were extremely upset when we told them they couldn't use the blue lights and drive under emergency conditions, but it worked out reasonably well. Next slide, please. I thought I'd say a little bit about the NHS. So the NHS was established in 1948. It's generally regarded as one of the greatest assets to the UK. It's free at the point of delivery, and it's a phenomenal service. It employs not far off as many staff as the Chinese railways, and it's been the origin of many amazing discoveries and interventions. However, next slide, please. It's not having a great time just at the moment. We're massively overspent. We have a shortage of nurses, and for the first year ever, the number of people going into nursing has fallen. We have got a shortage of midwives. We have a number of highly critical reports on maternity units in the UK, where regulatory bodies have found midwifery units inadequate and have cited a number of serious failings. We're seeing many junior doctors leaving the profession or going abroad. We're seeing the numbers going into primary care reduce. We've got issues around pensions, and we have a national shortage of paramedics and real problems in not just recruiting, but in particular retaining paramedics. Next slide, please. We've got a disillusioned and disaffected workforce, many of whom are unhappy about the way that they're treated. As you will be aware, ambulance staff went on strike, not just, as I mentioned, in 2014, but also in 2022 and 23, although their pay demands have now been settled and they are now back working normally. However, you've probably seen in the press that junior doctors and consultants have both been on strike this year, and over the last 2 days, consultants and junior doctors were on strike concurrently. That's the first time that's ever happened. And essentially what that means is that pretty much all elective care and outpatients is paused. Emergency care continues, but it does mean that our waiting lists, which are currently standing at over 7.8 million, are inevitably getting longer. And we are having real difficulties getting the government to engage. They are taking a very entrenched position, as, to be fair, are the junior doctors and consultants. So at the moment, there's no movement there. And A&E 4-hour performance, which was brought in back in the late 2000s, has been the worst since records began. It fell dramatically during COVID, but it's still less than 80%. And we are seeing very long offload time for ambulances outside EDs. This is not the problem of the ED, it's the problem of flow through hospitals. So if you don't have a social care system that will allow patients to be safely discharged from hospital, then the hospitals, essentially the flow through the hospitals slows, the flow through EDs becomes much slower, and ambulances cannot be offloaded. Next slide, please. So what have I learned through all this? It's all about culture and addressing culture change. It's around ensuring that people, wherever they are in the NHS, but particularly in ambulance services, feel that they're in a position to report incidents when things don't go according to plan, that they will be supported in that, because there's still the feeling that they will be hung out to dry. And throughout the health service, we can demonstrate that whistleblowers come to harm. We need a clear strategy going forward. And for me, particularly, the lessons that I learned, particularly in South East Coast Ambulance Service, were around medicines management, where when I went there, we had a real issue around demonstrating that we were keeping our drugs safe and secure. And inevitably, in a service which is over a large area, both within London and in South East Coast, ensuring that your vehicles are safe and your premises are safe, because many of the items that you use on a day-to-day basis are of interest to people who may not necessarily want to use them as they were intended. And there's always the danger of an ambulance being used as a Trojan horse. Next slide, please. But it's important to celebrate when things really go well. And I think I would highlight the introduction of critical care paramedics in South East Coast Ambulance Service. We have a cohort of over 70 critical care paramedics. And it's difficult to quantify the benefit that they bring, but the ability to go to a patient who's got a return of spontaneous circulation and to ensure that they are adequately sedated or paralyzed and have a smooth and controlled journey into hospital is so much better than leaving a paramedic struggling with an eye gel in a patient who's starting to wake up following a return of spontaneous circulation. We've got 2 new control rooms in South East Coast Ambulance Service and the opportunity to really maximise the benefits of proper call taking and dispatch. And we also have a very sophisticated make ready centre where ambulances are properly cleaned both inside and out, properly kitted out and ready for the next oncoming crew. We also have a series of urgent care practitioners who are tasked to those lower acuity but much higher morbidity and patients with multiple conditions to try and avoid admitting them to hospital, but ensuring that they are referred to more appropriate areas of care. Next slide, please. Then FEM training, or pre-hospital emergency medicine training. We've now got a comprehensive syllabus for those doctors from emergency medicine and anaesthesia to undergo a training programme as part of their subspecialty training. Next slide, please. This is overseen by the Intercollegiate Board for Training in Pre-Hospital Emergency Medicine, which going forward will be overseen by the Faculty of Pre-Hospital Care of the Royal College of Surgeons of Edinburgh. It's a new subspecialty, and it's very much focusing on the on-scene and in-transit critical care of a patient. There are 9 training programmes, 7 in England, 1 in Wales and 1 in Scotland. But I'm a bit sad that at the moment there's minimal focus on medical direction. So it's very much about treating seriously ill and injured patients rather than looking at the overall care of patients being treated by ambulance services. So next slide, please. I'd also like to highlight the international perspective from a couple of areas. Firstly, from the Gathering of Eagles. So this is a group comprised of the medical directors of the large metropolitan EMS system leaders and a smaller number of international delegates. They meet yearly at Eagles Creek when we sit down for 2 days of just talking about stuff, which is incredibly valuable. We share our problems, we share our solutions, and that's followed by a state of science conference attended generally by between 900 and 1,200 delegates of a multidisciplinary background, all hosted and run by Paul Pepe and Ray Fowler. It's an amazing resource, not just the conference and the opportunity to get together, but the group of people where you can put a question on the internet to this group and get 40 replies back in as many hours. So if you're looking at your policies, your protocols, and whether you're going to change something, getting a view from this group is immensely valuable. Next slide, please. I'd also like to highlight both the Global Resuscitation Alliance, which is why we're all here today, but also the European EMS Leadership Network, which has held some amazing conferences, 5 conferences over the years since 2016. So initially, conferences in Copenhagen in 2016, 17 and 18, and then a fantastic conference in Madrid, and then last year, a conference in Glasgow. These are very well supported by Europe and internationally. They highlight and showcase some of the most amazing speakers and workshops. Next slide, please. Important, of course, not to forget the impact of this little thing, this virus, the impact that COVID has had on all our lives, not just on the ability to run conferences between 2020 and 2022, but on the impact on all the vulnerable patients who suffered in all our countries, on the children and their education and the impact that we are continuing to see on the health services and all those people who have been impacted by long COVID. But on a positive side, for the race for developing vaccines and the ongoing vaccine programme, which has just kicked off again a little bit in advance of where we thought it was going to be in the UK this year, just because of the concerns of both influenza and COVID, and the inevitable increase in demand on the health service that we see in the winter. Next slide, please. So I think the next is probably one of Freddie Lippert's sayings. But for me, this is about the people. It's about how do we recruit and in particular retain the best staff. We've historically educated our staff in pre-hospital care for the 20% of the really high-end work, whereas 80% of the work is what we're seeing all the time. This is how to ensure that patients who might not need to go to a cardiac centre or a stroke centre and have many more mundane conditions are directed to the most appropriate place to be well and safely looked after. It's a stressful job. It's stressful whether you're dealing with the really sick patients or just the sheer demand of the number of calls that are taken both in the control rooms and out on the road. And how do we maximise the professionalism of all our staff? Remembering that paramedicine is a very new profession. The first paramedics in this country, and Douglas will correct me if I'm wrong, but it was back in the late 80s, early 90s, when Douglas introduced his paramedic training programme in Brighton. So it's, compared to nursing and to medicine, it's a young profession, and it's one that we need to nurture and grow. I guess there's also something about maximising the benefits of technology. So next slide, please. And for me, this is around maximising the benefit of control rooms and the integrated clinical hubs. We've seen huge benefits from video streaming. I went to an international conference on Good Sam at the end of last week, which demonstrated just the impact that Good Sam has had, particularly with its video streaming across the world, both in health services and for the police. Pre-hospital care is a multidisciplinary sport. We have an increasing number of nurses in our control centres, but also in specific roles within ambulance services. We now have embraced pharmacists to keep our medicines management safe. And as I mentioned earlier, the benefit of having midwives influencing in particular the training of our staff. And we've seen that in particular through the training of our critical care paramedics, who are able to talk frontline crews through some very difficult maternity emergencies. Allowing our staff to rotate, not just through all the areas where they did historically, but also through primary care, minor injuries units, paediatric units, and integrated clinical hubs. And currently, ambulance services are required to have medical directors, but surely, given that most of our staff are paramedics, should we not have clinical directors and recognise the benefits that senior paramedics bring to our ambulance services and to EMS? Next slide, please. So for me, what am I going to do now? Well, I've stepped down from South East Coast Ambulance Service. I'm now working for this organisation. And what has been really scary is that the doctor I'm working with there was a medical student with my son. That made me feel about 150. Next slide, please. So a big thank you to the people who have supported me throughout my journey. And anybody who's ever seen any of my talks before will know that my dogs feature large. Sadly, the two dogs in the lower part of the photograph with my 3 kids have gone over the rainbow. But the ones that you see at the top are the one that I currently have and the one that I'm picking up next week. And you can see that there's a large puddle beside that one. So it's going to be a busy year. Thank you very much.
Wow, Fiona, that was terrific. There was, I think you're getting some applause from a few online here, including Dr. Chamberlain. So that was a whirlwind. Lots of great pictures. I think the photos were really quite telling and sort of highlight all the experiences. So we certainly welcome it if folks have questions for Dr. Moore. You can put those in the chat. I probably in about 5 or 10 minutes will ask Dr. Chamberlain for sort of final comments. So I don't know, Douglas, if that's something that you would like to do, but we certainly will give you that opportunity. I would like to start, Fiona, by I think there's one very specific question about operations, and then a more sort of general philosophical question. You mentioned a couple of times this idea of critical care paramedics. And so I guess I want to understand from your perspective, what defines a critical care paramedic? You talked about someone managing an airway with sedation and paralytics. Are there other features? And how in England is that endorsement or certification is established and administered?
So that's a great question, Tom. And it's not the same in all ambulance services. So there are a couple of services that do not have advanced or specialist paramedics, but the College of Paramedics in the UK is looking at setting out the competencies for paramedics, specialist paramedics, advanced paramedics, and consultant paramedics. And you can look at the 4 pillars that support paramedicine. So education, research, clinical practice, and each of those has to be represented within the development of a paramedic. So once a paramedic has completed their initial training, they undertake a period of 2 years as a newly qualified paramedic when they have mentoring and support. They then can either remain as a paramedic or they can look to undertake specialist training. From a clinical point of view, there are currently 2 routes. You can either become an urgent care paramedic, which is dealing with the lower acuity, higher morbidity or comorbidity sort of patient. So the patient who's got an exacerbation of COPD, an exacerbation of heart failure, or go down the critical care paramedic route. Now, in South East Coast Ambulance Service, Professor Andy Newton, back in probably about 2010, maybe even earlier, set up training programs for both those groups. And that's been really successful. Both have underpinning university courses to support that. The problem we found with the urgent care paramedics is that they are very, very attractive to primary care. And although we trained somewhere in the region of 300 urgent care paramedics to a higher level, something like 200 of them have gone off to work in primary care. Critical care paramedics have been, the retention has been very much better, and we've lost many fewer. We have now got a very good rotation between our CCAM critical care paramedics and being a flight paramedic with the Air Ambulance Charity of Kent, Surrey, Sussex, and that's been very successful. But the skills of a critical care paramedic are advanced interventions, so advanced airway. So for most ambulance services in the UK, intubation has been withdrawn as a skill, and the only people undertaking endotracheal intubation are critical care paramedics. That's certainly the case in my service and in London, and I think in other services, just because most paramedics do not have sufficient exposure to undertaking regular advanced airway interventions, but they do have the iGel, and that's universally used in cardiac arrests in this country.
Well, it's interesting. And do you have I wonder if some of these roles and titles are the equivalent of our EMT, so emergency medical technician? I think not. I think even in Britain, I think in Britain, the paramedic is sort of like our paramedic, and then you have the critical care stature. So do you have an equivalent of an EMT in?
Yes, we do.
You do?
Yes, we
Okay.
do. So historically, you became an EMT when you did your initial basic training, your 6 weeks training. You became an emergency medical technician, and then you had a year where you were basically mentored and trained, and then you took a sort of exit exam. We don't call them technicians anymore. We call them emergency care assistants. Different services have different names for them, or advanced ambulance practitioners. So there is a basic level entry. There are also in our service an emergency care support worker, which is basically a support worker who has a much more limited scope of practice. Then you can go on to be what was essentially the equivalent of the previous technician, and then you go on to be a paramedic. Now, currently, paramedic is a degree qualification. I think going forward, we are looking more at a more apprenticeship-based training, because sending somebody off to university for 3 years when they've just left school and undertaking placements with an ambulance service is probably not as valuable as an apprenticeship with regular input from the university rather than being university based.
So this idea that you learn the craft while you get the education, right?
Correct.
There are clearly advantages and perhaps disadvantages to that model, but I think sort of learning about something and then doing it almost in contemporaneously, so at the same time, is clearly an advantage for most learners, and it sounds like that's a good plan that you all are moving forward with. I think that makes a lot of sense. Well, Fiona, let me ask a more philosophical question. You've worked, as you highlighted, in a number of large ambulance services as the medical director and as a chief executive officer. When you are leading these groups, what would you say, as you talk to the group, our audience, what are the most important components of leadership? What do you consider sort of the 1, 2, and 3 as you think about how you led those organizations?
I think for me, getting out and talking to the staff, really understanding the work that they were doing, the challenges that they had, what was really important to them, what we needed to fix, how they could be supported and valued, and how they could be respected both by their patients, by the public generally, and also by each other. Because historically, the ambulance service, certainly when I first came into the ambulance service, it was a very male dominated, often sort of blue collar worker, and it's changed dramatically, so that now more than 50% of the people coming into the service are women, and the majority are coming through higher education. So their expectations are very different. So understanding from them what their expectations and aspirations are, and I think also trying to ensure that the ambulance service is not, or EMS is not just the Cinderella service that people only think about at the end of the day, because we are essentially the glue between primary and secondary care. And if we're not involved in the decisions that both those sides of the NHS make, then things aren't going to work. And historically, the ambulance service has always been thought of last. Now, I think one of the things that really came through during COVID, with the horrendous delays that we saw outside hospitals, was the criticality of the ambulance service. If you can't turn your ambulances round at hospital, you can't get them out on the road again. Now, hospitals tend to believe that patients only become ill as they roll on the trolley through the ambulance doors. But to make them understand that the risk in the community of those patients who are unseen unlike the patients that are sitting outside the emergency department who at least have been assessed, and the patients in the emergency department who are undergoing care, whereas the ones that are still waiting in the stack for us to get to them is a massive risk. And that penny has finally dropped with the hospitals. Doesn't necessarily mean that they still turn us around as quickly as they might, but I think they are more appreciative of the risk that the patients in the community who have not yet been seen, and all we've been able to do is to talk to them on the phone and give them a priority, which might be a priority reached 5-6 hours ago, and that might have changed.
Yes, I think some of the experiences that you've had in England are likewise occurring everywhere, and we have had the very similar types of experiences. Well, I see that Dr. Chamberlain has come off mute, and I'm grateful for that. And we're getting close to the end of the hour, and so Douglas, would you can either make a comment or pose a question. This is your time, and thank you so much for joining us this evening.
Well, it's been very interesting. Some of you may not be aware where resuscitation was taught regularly, which country had the early lead in resuscitation. I'll give 10 points to anybody who gets it right. Well, it was in fact Russia, and nobody got it right. So I got involved in resuscitation back in 1966, and I had the great pleasure of having a Russian come over, and we had somebody to translate for us, and that was a very interesting experience. I am actually an expert at some things. The thing I'm best at is actually standing on the shoulders of others, because I often get the credit for things that have been done by other people. And I'm always, of course, delighted to pick up credit that I don't deserve. And I've had a lot of that. But it has been a very interesting time. My interest in resuscitation and my involvement with the ambulance service. I still look at the transmitted electrocardiograms every day. And it's nice to have some involvement, because it's really such a worthwhile business in resuscitation.
So in closing, maybe I'll ask Fiona then to sort of reflect a bit and talk a little bit about this, as we say, standing on shoulders, this idea that prior generations influenced you. You talked about meeting with Douglas. How did that interaction come to pass, and what has been Dr. Chamberlain's influence on your career?
So let's say it didn't go terribly well. That I was on a course that Douglas was teaching on back in when I was a senior registrar, and he put up an ECG, and I looked at it and I thought, I don't know what the hell that is, but I thought I'd be really clever, so I said something along the lines of I thought that was sort of an arrhythmia with I can't even remember what I said, but he basically clobbered me with his stick and told me I was stupid. And he has continued to be a phenomenal teacher. And the idea that terror teaching doesn't work is undoubtedly true, except with Douglas, because the students seem to be entirely happy to be hit about the head with his walking stick when they fail to make a simple diagnosis. They absolutely love him. And we have named one of the ambulance stations in Southeast Coast Chamberlain House. And if you go to that ambulance station and you go up the stairs, there is a larger than life picture of Douglas with his walking stick. enough to inspire, stroke, terrify any aspiring ambulance paramedic. But no, Douglas has done a phenomenal amount. And as he says, he continues to go through ECGs on a daily basis to highlight areas where we need to take a machine out of service and get it sorted out. So I think the debt of gratitude that paramedics in the UK owe to Douglas, and the fact that he essentially started paramedicine as we now know it, and it's thriving. We now have a significant number of consultant paramedics, and the opportunity to continue to develop this profession going forward.
Yeah. Well, Fiona, I think in closing, I would say this same debt of gratitude goes to you and your steadfast leadership and sort of, I think, common sense. We might call it British over here, British intelligence that really has helped shape the way we do EMS on this side of the pond. And it really is a treat to get to talk with you and to have you share your experiences, and I think we call it wisdom at this juncture. And so we want to make sure that, I think we want to ask, and we will probably want to share some of your slides. So we'll circle back with you on that, but really appreciate your staying up a little later this evening and sharing your story and motivating us to continue to do this very important job. So thank you, and thanks to everyone who's attended, in particular, Dr. and Ms. Chamberlain. We appreciate you staying up late, and we look forward to you all joining us in October. So thank you, everybody.
I do recommend Teaching by Terror. Nothing works as well as Teaching by Terror.
I think Michael Kopis would agree with you. He likewise could
Yes.
stand at attention pretty quickly.
Right.
All right, thanks everybody.
Thank you, and thanks to Tegan for support.
Yeah.
Thank you so much.
Thanks.